Some of you may have met me via the our little webcast a few weeks back. So some of the information may be a little redundant, but hopefully not all of it. But I do appreciate you joining us. Hopefully you'll find this educational. I'm pretty down to earth and personable guy. And so when we get done with this, I'll try to leave some time for us to just talk somewhat casually and allow you guys to ask questions and see if we can help answer those. So with no further ado here, I'm going to see if I can share my screen and see if we can get this going. All right, so the topic today is reverse shoulder arthroplasty, and it's kind of been a hot topic over the past 10 to 15 years with really growing popularity in more recent years. And one of the most common questions I get on a daily basis when we're talking about a shoulder replacement is, so what is a reverse? And so hopefully we can help answer that for you today. Just in the way of who I am, I'm one of the newer shoulder and elbow guys here to Knoxville. I'm not new to shoulder and elbow, but I am new to Knoxville somewhat. I grew up down in Georgia in a small town. That's my quaint little hometown there. But no mistake, I've spent plenty of time in Knoxville and East Tennessee. I lived here for 4 or 5 years prior to returning to Knoxville. So I did live here and made my fair share of Tennessee football games, et cetera. So I'm no stranger to East Tennessee. I did my undergrad at Georgia Tech, did my medical training and residency at the Medical College of Georgia down in Augusta, Georgia. Unfortunately, we just found out that Augusta National will not be admitting patrons to the Masters this year. So that was unfortunate, but they just announced that just a few hours ago. But in any event, I spent a lot of time down there, and then I went up to do a fellowship in shoulder and elbow reconstruction up at the Mayo Clinic in Minnesota. It's been rated the #1 hospital, I think 3 or 4 years in a row now. I trained with a lot of the researchers and implant designers for the majority of the major shoulder systems in the United States and worldwide. So it was a phenomenal year of training. We did more complex shoulder arthroplasty each year up there than is done anywhere else in the United States. And it is one of the few shoulder and elbow surgeon recognized programs. Myself, I'm one of the shoulder and elbow recognized members, and I believe there's 5 of us in all of East Tennessee. That's including Tri-Cities and Chattanooga and Knoxville. So there's not a big number of us that have done that type of training, but I had a wonderful experience up there other than the weather. And we did close to 500 surgeries, published a bunch, did a lot of research that's been presented both nationally and internationally, worked on some textbooks, things of that nature. So did a lot of great stuff up there. This was a picture of my family and us up there in the cold north. And so while it was great to train up there, I'm much more happy that this is the view that I get on a daily basis of East Tennessee in the fall. That is much more what I enjoy and my family enjoys versus the snow of Minnesota. So the topic again today is reverse shoulder replacement. The short answer to what is a reverse is that this is an answer to our prayers. The reverse has come along in the past 15 years, and it essentially enables a shoulder surgeon like myself to treat patients with problems and conditions that previously we really had no good solution for. So I've listed 4 or 5 of these below, but essentially there's problems with the rotator cuff, problems that can no longer be repaired. When you have arthritis and an insufficient rotator cuff, you can develop arthropathy, which can even further progress to what we call pseudoparalysis, where your rotator cuff is working really not at all, and the entire biomechanical structure of your shoulder is out of whack. And so because of that, you just can't lift your arm, and you become almost paralyzed with that affected shoulder. Sometimes people have had prior surgeries, and they may have an unstable shoulder that was previously, sometimes they never work well from the get-go, but other times they work well for a period of time, and then they kind of fail with time, and they develop this instability and escape, and this can cause quite a bit of problems. And then sometimes fracture management is managed with reverse shoulder replacement. So you can see a whole host of pathology and reasons that we may consider doing a reverse shoulder. So the layout today will be to talk a little bit about anatomy and indications. We'll talk about what the difference is in reverse and anatomic shoulder replacements. We'll talk about a little bit of biomechanics and history, and then we'll talk about some of the newer things coming down the pipe. So in order to understand abnormal, you have to first understand normal. And so this is what we consider a normal ball and socket joint of the shoulder. You have your humeral head, which is over here on the left. It's a traditional ball and socket. So your ball is here, your socket is here. And then your humerus is your arm bone coming down to meet the elbow. The socket is the glenoid, but that's it's just an extension of the actual shoulder blade or your scapula. And then up on the top, you have your collarbone and your acromion. So that's the overall basic structure of the bony anatomy. When you move forward, you think about, well, what keeps the shoulder stable? It certainly can't just be the bones. Well, what you come to find out is there are a whole host of capsules and tendons and rotator cuff that all help stabilize the shoulder. So it's truly a dynamic joint. It's the most unconstrained joint in the body. And so I affectionately and lovingly like to share with my knee and hip partners that do knee and hip replacement that really anybody can do a knee and a hip. It really takes the smart guys to be able to do a shoulder. And I say that jokingly, obviously, but I like to give them a hard time because the shoulder is a very complex joint and is a very unconstrained joint. And so because of that, we have a lot of factors that we have to consider in order to think about solving a problem and creating a good outcome. So this is what a normal shoulder x-ray looks like. You'll notice the ball again here and the socket here. There's joint space maintained with this dark line in the middle. So this is a relatively normal looking x-ray. A diagram of what arthritis looks like is here. You see there's no longer a smooth surface. And if you look closer, the analogy I give people is that this is a hill of snow slopes, and it's the equivalent of a nice smooth cartilage cap on top of the ball and socket. This enables people to have a smooth, non-friction type motion that is relatively pain-free. So for most of us, that's what we've experienced for many years of our life. Well, unfortunately, as people go skiing down the snow slopes there are ruts and divots that are carved into the cartilage or into the snow. And the same thing happens as we undergo wear and tear of our shoulder. Well, as the snow begins to melt, so does the cartilage, and the cartilage can be worn away, and these ruts become essentially big craters. And so as the snow melts, you're left with a rocky surface underneath of the mountain. And that's the same thing that happens in the shoulder. The cartilage is worn away, and underneath you have raw bone. And that bone is what we talk about, bone-on-bone arthritis, just like you talk about in the knee or the hip. And it's incredibly painful. And so again, a normal x-ray there on the left, and osteoarthritis or arthritis you see on the right with just no joint space. You have bone spurs forming down here at the bottom part of the ball, and the joint space that was preserved on the left is no longer present on the right. And so this is bone-on-bone arthritis. I know at least one of our patients here on the call here has seen her x-rays, and she could tell that hers is far more progressed than this patient's here. And so we see this in an entire range of spectrum, but this is relatively advanced arthritis, but unfortunately I see patients that have dealt with this for a number of years and can get even more impressive than this. This is a surgical photo. Again, on the left, you'll see a very smooth surface. This is the humeral head, a nice smooth surface. On the left here, you'll see the glenoid or the socket, very smooth, white, happy cartilage. And then here on the right in the bottom picture, you'll see that this humeral head and this glenoid are not at all happy. There are ruts and divots in it. This is raw exposed bone. There's no longer cartilage on it. So you can imagine this is a very painful situation for these patients. Well, when we think about the other reasons that we might talk about reverse, we'll talk about the issues here. And sometimes you have a rotator cuff tear that can be fixed. Unfortunately, sometimes you have a rotator cuff tear that can't be fixed based on the quality of the tissue or the size of the tear or the way the injury happened. Sometimes rotator cuff tears are no longer able to be fixed. And so that's a big problem. We don't have a great solution for that. And as that progresses, you can advance to what we call arthropathy, where the ball is no longer centered in the socket. And so as that ball rises up north toward the ceiling, you realize that, well, there's no way the soft tissues and the tendons can adequately raise and move the arm because the mechanics are all off. You no longer have a well-balanced joint. And so because of that, people have a fair amount of dysfunction as well as pain. This is one of our patients that went from what we call cuff arthropathy, like we were just discussing, to he has true pseudoparalysis. So this gentleman came in to see me, and you can see his motion on his right side is okay, not great, but okay. But on his left, you can tell if you cheat a little bit and look at the picture in the middle, you can tell he's grimacing. He is trying really, really hard to lift this arm. He's a tough old guy and has dealt with this for a long time, and he's trying tremendously hard in order to lift this arm, but he just can't do it. And so that's when you truly have pseudoparalysis. And this gentleman has lived with this problem for almost 10 years before coming to see me because he was previously told there was no good solution for him. Unfortunately, sometimes people have already had surgery. So this is a patient that had prior shoulder replacement surgery and unfortunately was not done very well, technically speaking. And then also sometimes they are done well, but the rotator cuff just gives out. And when that happens, patients can demonstrate what we call escape or instability, where this patient, when he activates his muscles to lift the arm, the ball actually escapes out of the joint and kind of comes out in the front and toward the top and in the front. And so again, you functionally are not able to lift your arm. And so these patients tend to be not always terribly painful, but they do have very limited function and sometimes painful as well. And so this is sometimes the long-term consequence of a prior surgery that has unfortunately gone awry. And then, like we talked about, fractures are a big problem. Nobody plans to fall, but when we do fall, as we get a little older, sometimes our bones give way and we fracture and we break our bones. And sometimes the fractures are so bad, like the one on the right, that there's really no feasible way to reconstruct this and put it back together using your own native bone. And so in that situation, we may talk about doing a replacement, a reverse replacement from the get-go in your initial surgery. Other people come in and they've had a beautiful looking surgery and we think that everything has gone well there on the right. And over time, more problems progress, and eventually I like to tell people the ice cream on top kind of falls off the ice cream scoop. And so sometimes that happens. And so even though this looked great right after surgery, sometimes that fails. And when it does, we have to go back in and reconstruct it. And fortunately, we have a good option for that now with a reverse replacement. Formerly, if you went back 15 or 20 years, this patient would really not have much good option. Traditionally, what we did was what we call a partial replacement of the shoulder. And unfortunately, that was not a terribly functional implant for most people. It did a pretty good job of relieving pain, but most people were never really able to get their arm back anywhere close to the level of their shoulder, or certainly not overhead. So the reverse replacement has really been an answer to a lot of our problems and our prayers over the years as a shoulder surgeon. And so what's the difference? What's the big deal between a normal TSA is total shoulder arthroplasty? So what's the difference in a normal shoulder replacement and a reverse replacement? Well, again, in order to understand what's different, we have to understand what's normal. So when we talk about an anatomic or a traditional ball and socket shoulder replacement, the ball, which is here, is replaced with a ball. And so the stem of the prosthesis and the ball replaces where you previously had a normal ball. And on the socket side over here, on the scapula side, we replace the socket with a polyethylene or plastic implant. And so we kind of recreated a cup and a ball and socket the way God originally made us. Well, if you take that and you compare it to a reverse, if you look at the similar diagram, you'll see that the ball is now on the socket side. And we've taken the plastic cup and taken it from the socket and we've placed it over here on this, where the ball previously was. So it is now, it essentially reverses the normal ball and socket configuration. You know, the guys that created this and figured this out are European fellas, primarily from France, back many, many years ago in the 70s. And I don't know who thought it was a good idea to originally do it. But all in all, we realized with many, many decades of testing that turns out they were onto something. And so why does it work? Well, what happens is that we move the moment arm and we essentially change the mechanics of the shoulder so that we decrease our reliance on the rotator cuff, and we put all of our prime stock on the use of the deltoid. So the deltoid, which is the big outside muscle of the shoulder, is now the primary workhorse of lifting the shoulder. And so we've essentially, in some respects, negated the rotator cuff. Now, certainly for me, if patients have a bad rotator cuff, but they still have some good rotator cuff, then I certainly try to take advantage of that and use that during the reconstruction, because I do think it benefits people. And frankly, my thought on it is that if it's there and it's working, then we should save it and utilize it. So if we think about the biomechanics of it, and I don't want to get really deep into physics, but people do ask this, but when we say, well, you know, what are we doing here with the reverse? Well, the deltoid is this big muscle on the outside of the shoulder, and it's got a front, a middle, and a back or rear aspect of the shoulder. And so as long as this muscle is working well for you, then what we do is we found a way to move the way the shoulder lifts, and we've increased the tension on the deltoid, which increases your joint compression, which allows the shoulder to elevate again. And so we've taken a shoulder that you previously couldn't lift, we've shifted the work to the deltoid, and now the deltoid's able to fully lift the arm up. And so previously you had a patient, like I've shown you before, that couldn't even begin to lift their arm, and now they're able to lift their arm up to, pretty close to normal level. Oftentimes it may not be perfect compared to the other side, but it's certainly better than the options we had years ago. And the vast majority of my patients get their arm well back over their head. So shifting gears just a little bit, in the way of history, like I said, a little bit of a history lesson here. The bright guys over in France and Europe and Germany, et cetera, were the guys that really figured a lot of this stuff out back in the early 70s and 80s. You can see these designs that I've pulled. You can imagine the one on the right here looks pretty archaic. If you can imagine that going into your shoulder, I guess somebody signed up for that, but I'd be hard pressed to do it. It looks quite like a medieval torture device maybe, but in any event, this was where things started. If you fast forward into the 80s and 90s, the same groups over in Europe really made big strides in progress in figuring this thing out. They changed the designs many times. And the design over here on your right, this is what we call the Grammont prosthesis. This was really what paved the way for this being re-released in the United States, and was kind of the stepping stone to us having a solution here in the United States. So when this came out in the early 90s, the United States was not on board with it. And so it took until almost 2004, it was the very end of 2003, that the United States and the FDA wanted to wait until they had more 5 and 10 and 15-year follow-up from Europe before they approved the use of this device. So it got cleared by the FDA in 2003. And then this is a graph here that if you look at the bottom, this was the use of shoulder replacements, this blue line here. And you can see it's pretty low. It's a pretty straight, just a very narrow or a very small incline from basically 92 to 2002 or so. And then here, right here where the blue arrow is, this is when the reverse was released. And you can see that between 2004 and 2008, the rocket, it just took off exponentially and started going up at a really rapid pace. And then I have another graph I'll show you in a minute, but if you expand that another 10 years, the growth has done nothing but accelerate. And the reason that is because all of a sudden we have a great solution now for problems that we previously didn't have a solution for. And then if you look now, even in the past, since the release in the mid-2000s, over the past 10 to 15 years, our materials have gotten exponentially better. Our designs have gotten exponentially better. And so we really are progressing at a rapid clip and getting much, much better. These are some of the things that I thought were impressive. This was the, over here on the left, the size of the old stems that they put in. And then if you progress, this is like the evolution of the stem now. And so this is the size of the stem that I put in now in probably 98% of my patients. And so it's really very short. It preserves bone. It's very friendly to the body and allows still for the same great result. But fortunately, we have the ability to think about, well, what if something does go wrong and we were to need something done down the road? We haven't burned bridges. And so that's really what's happened on the stem side that goes into the arm. And then on the socket side, these base plates have gotten much, much smaller. This is a blown up view of it, but really this is only about 24, 25 millimeters. And so it's really itty bitty. It's about an inch and a half really. And so it's really not big. And so we're able to do all this with a much smaller implant. We preserve a lot of your body's own bone, which allows us, one, we feel like it's less painful. And two, I think it allows us some get out of jail free cards, meaning that heaven forbid something were to happen, you have a fall or something were to go south down the road, we have a backup plan. Whereas the way we were doing it 15 years ago, you had one good shot. And if that didn't go well, I will tell you, it is a mess to fix that. And so I'm really excited about the future and the things that I've worked with a lot of the guys that help design these things. And I'm just really excited about the technology we have now, as well as the things to come. This is some of the technology I use on a daily basis. So I pre-plan all of my surgeries. I have a CT scan done, and I come up with an exact plan for every single one of my patients, or I say every single, probably 98, 99% of my patients. And so I have a really good plan beforehand. Before I ever get to the operating room, I know what sizes I'm going to probably use. I know if I need any special instrumentation, if I need anything extra that needs to be delivered in, I'm aware of that, so that I'm not going in with a plan of, well, you get a small, a medium, or a large, and that's all you get. I really truly have a custom plan for most patients when we get in there. And then beyond that, what we're doing now is we're doing 3D printing, where we have a 3D model printed of your shoulder. And then we have custom guides and instrumentation made that allows us to put those implants reproducibly back in the right spot and kind of the perfect spot, the way it was meant to be. And so, it's not foolproof. I can't say that no one has ever had a problem with this, but I certainly think we have good studies to show that it's more reproducible. It's and quite frankly, if we put the implants in the right place, it stands to reason that these are going to last a lot longer for patients and give them a lot more function and less pain than the way we traditionally did it, with kind of, I won't say one size fits all, but it was kind of one size fits all. And so I definitely think this allows us to provide a better outcome for patients. So this is one of my patients that came in. He's a retired dentist, and he came in this is 6 weeks from surgery. I'll see if we can get this to work. So he said his preoperative pain was completely gone, and he had a custom reverse done. And you can see this is only 6 weeks out from surgery, so his motion will get better, but already he's doing great. And, again, he was just in my clinic a few weeks ago, and, he's doing great. He has no pain. His motion's great. And so, the knock on the reverse for many years was that you never could get your arm back over your head, and people didn't do that well. And, my personal belief is that was because, frankly, we were not probably doing the procedure technically the way we should. And we had a lot of people doing the surgery that probably shouldn't be doing it. To be honest with you. And so I say all that to say, this is what I expect out of my patients. I expect that you're going to get your hand back up pretty darn close to the other side. And so in terms of outcomes, what can you expect? Well, I tell people that the number one reason to do it is pain. And you should be able to expect a decreased pain profile. We expect an increased range of motion in most people. Along with the decreased pain and increased motion, typically function goes up. Increased strength is a little tricky, but for a lot of people, we do get increased strength. It kind of depends on where you begin. There's some people with a lot of retained strength that may not get that anymore. And there are some people that may not get all their strength back, but they get enough strength that they can still get a good functional motion, as well as a decreased pain profile. And that's really what most folks are after. So this is a study just comparing it to knee and hip replacement. We have a number of good studies that show that you have about a 95% reported chance of having less pain with shoulder replacement than you did before, and that the efficacy of this in relieving pain and being a safe procedure is pretty similar to hip and knee replacement. And so while people think more about hip and knee, I would assure you that I would put most of my shoulder replacements up against the majority of my knee and hip partners any day. I actually have a lot of patients that tell me the shoulder is a lot easier to recover from than the knee. This was another one of our patients. She was unfortunately on chronic pain medicine because of her shoulder pain before surgery. 6 weeks after surgery, she was essentially off pain medicine. She was taking maybe one pain pill a day, whereas she was previously taking many, and said, look, doc, 90% of the time I'm pain free. I'm amazed, and you can see her motion here. At 6 weeks, she looks like she's almost equivalent on both sides. And then this is a picture of her scar here just to show you she was only 6 weeks out. It's not she wasn't at a year out. I wasn't trying to pull a fast one on you. So in terms of comparing the outcomes, I looked up some studies to present with you. And, people always want to know, well, which one is the best one for me? And what I tell people is that fundamentally, I would love to do an anatomic shoulder replacement on every patient if I could. But fundamentally, it's not the right answer for everybody. And so if it's not, and you don't have a good rotator cuff, or you have a bone problem that would make you not a good candidate for a traditional anatomic total shoulder, then I would be doing you a disservice to give you an anatomic and not give you a reverse. And so fundamentally, I typically, I make a final decision intraoperatively after I've seen the bone and the tendon myself. But on the front end, I do everything I can in my power to prepare the patients for both options. And we talk about both options. Or I may be very frank with you and tell you that, an anatomic is just not what's best for you. And you're 99% chance you're going to get a reverse. And so, I try to be very honest with people. I try to educate people and allow them to be involved in their decision-making as much as is possible. But what you realize is that when you look at both of their results of both procedures, they're both highly successful. And so with an anatomic shoulder replacement, I do think people feel a little more natural than with a reverse. And if you compare their pre and post-operative scores and range of motion, an anatomic shoulder replacement probably does give you a little bit better post-operative range of motion than a reverse. But that's also because the majority of those patients have a functioning rotator cuff, and they also started with a better pre-operative range of motion. And so it's really not fair to compare, it's like comparing apples and oranges. It's not apples to apples. And I say that because if you start off with better motion before surgery, chances are you're going to end up with better motion after surgery. So it's not always fair to compare the two. But on the converse to that, if you look at reverse shoulder replacement, they demonstrated significantly more effective results at improving outcome scores. And I think a lot of that is because people that need a reverse oftentimes have dealt with one of these horrible problems with an irreparable rotator cuff or pseudoparalysis or problems like that, or really advanced arthritis with bone bone problems and insufficiency. And so they've dealt with these problems so long that they put off surgery because they didn't think anything was out there that was available that would help them. So by the time they get surgery, their function is so bad and so poor on the front end that they really see a huge improvement in their outcomes on the back end after they've gone through with it. And so those are kind of the big differences. And so kind of in closing here, I like to review the steps to finding a right solution. And I would encourage you to find the right surgeon in the right hospital. So this was a continuation of that previous graph. And if you look at the estimated growth of shoulder replacement, it's projected to jump 300 to 700% in the next 20 years. And we've already witnessed this from 2010 to 2020. And it will continue to grow. And so when you're thinking about that, you go, well, hey, I'm going to start knowing more and more people that have had this done. And so because of that, you need to find someone that does this regularly. There was a study that showed that 75% of shoulder replacements were performed by someone that only does 1 or 2 cases a year. I would argue that this number has probably gone up. there are more people doing maybe 10 to 12 a year or something like that. But you really don't want someone, in my opinion, and I know I'm biased, but you don't want someone that's only doing, one of these a month. There are a number of studies that show direct correlations between surgeon training, volume, and outcomes. And so the people that are specialized and have had a fellowship and training in the shoulder and elbow reconstruction tend to have less complications and better outcomes. And the moral of the story here is that you don't always have to suffer with shoulder pain and a loss of function. We have, there are obviously, I exhaust all non-surgical treatment options before we talk about surgery, but if we do, you can rest assured that you have a high success of a good outcome, good pain relief, and a relatively low complication profile. And the goal of this really is to get you back to, riding bikes and playing golf and working in the yard and enjoying your life and the activities that you enjoy. You don't have to live with a painful shoulder. So I think that's the bulk of what I got, and I kept it right at 30 minutes as promised. And so this leaves us about 15 or so minutes where I will open it up for questions and answers.
Okay, everyone. I'm not sure if everyone can see, but there is a chat function at the bottom. That's anywhere you can type. Any questions you may have for Dr. Kennon. So far, we just have a thank you from Miss Debbie, Dr. Kennon. I'm not sure if you see that yet.
Yeah, I got it figured out here.
Perfect. No questions so far. We'll give it just a few more minutes. Thank you all so much. I'll be sending a follow-up email as well. This has been recording, so you can share it or go back and listen to it just for your reference, whatever you need. If you need
something to put you to sleep at night,
yeah,
this would be a good one for you.
If you need to schedule an appointment with Dr. Kennon, you can do so by going to our website, TOCDOCS.talkdocs.com, and you can click on Dr. Kennon's online scheduling. You can give us a call at 865-690-4861, or you can email us at feedback@TOCDOCS.com, and we can help you any of those ways. Okay, Dr. Kennon, I don't think we have any questions. I think everyone looks good.
Thank you. Well, hopefully everyone found that informative. And again, it's kind of what I'm passionate about, so I'm always happy to answer questions.
All right. Thank you, everyone.
Thanks, guys. Take care.